Thanks so much, Sarah, for the kind introduction, and thank you to you and Professor McShane and the organizers for inviting me to speak. I think that I think of this conference as marking the beginning of the COVID quarantine, since this was the very first meeting last year that I had to cancel and miss, and we all did because of COVID. So it's really a pleasure to be back with everybody today, albeit virtually. So I'm going to be talking about some of the long-term safety data that we have amassed at Janssen on our compound intranasal esketamine. And as Sarah indicated, I am a full-time employee of Janssen Research and Development, and I'm a shareholder of J&J stock. So when it comes to evaluating safety, we're very fortunate at Janssen that we have very large and long-term data sets in which we can do this. And I think Jerry mentioned we have two authorized indications for esketamine nasal spray, one in treatment-resistant depression and a second, more newly approved in Europe indication in patients with major depressive disorder who had active suicidal ideation and intent and were in a psychiatric crisis. I'm going to be presenting data from our TRD program, which in itself has studied over 2,000 patients and for a period of up to 4 years. So what we're looking at here is really the phase 3 development program for intranasal esketamine in treatment-resistant depression. So we had 2 short-term studies, Transform 1 and 2, in adults, and then a third short-term study, Transform 3, in patients greater than 65. And these patients were all then eligible to roll into longer-term studies. So we had our relapse prevention study or maintenance of effect study called Sustain 1, which adult patients from the short-term trials could go into, as well as a long-term open-label safety study that ran for up to a year, Sustain 2, that folks could enter directly at some sites or roll over from our elderly study. And then we have another study that's a continuation study that is ongoing, and that is Sustain 3. And that study was really designed to be a continuation of care study that would continue until the drug launched in the 27 countries in which it was running. And now we have launched in over 50 countries, but we also have continued that study in the US as part of a post-marketing commitment with the FDA for collecting long-term safety data. So what I'm going to present today is primarily going to come from this study at the last interim analysis cut. And then I'll supplement it with some additional data that we have from the Sustain 2 study. But just for your reference, the data from Sustain 2 have been published by my colleague Eva Wass, and is in the Journal of Clinical Psychiatry if you want to see the full data from that study. But the data I'll present today, actually this is the first time that we'll be presenting the data from this data cut. So in the Sustain 3 study, we ultimately had 1,148 patients enter into that study that had been participating in at least one of 6 previous trials. And I showed you the 5. Let me just mention that we had a small proportion of subjects from the US that actually are or have participated in our ongoing phase 3 program in China. So there's an additional 30 patients from the US that have rolled into that study. I'm getting a little feedback on my audio. I don't know if anybody else is, but maybe if folks can put themselves on mute, that would be helpful.
Yeah, I've just muted them, Carla. Carry on.
Okay, thank you. All righty. So so the data cutoff that we'll be using is actually May 2020. So it's actually the study has been running a year longer than the data that I'll present today, and those data, the newest data, have just been analyzed and are being written up into a study report. So in this Sustain 3 study, it's entirely open label, and patients could have entered into the induction phase, which is the 4-week, twice weekly dosing, or the optimization phase, which was generally weekly, every other week, and if patients were fully stable, they could move to once monthly dosing. And it was really up to the clinician as patients rolled in from their other studies into this study, whether they would go back into an induction phase or into the optimization and maintenance phase. And it was really based on how the patients were doing. And I think this will become a little bit more obvious here. So you can see that of the 1,148 patients that went into this study, 458 enrolled into an open label induction phase, where they then had the reinitiation of that 4-week, twice weekly dosing. And then another 690 patients rolled directly into the optimization or maintenance phase, where they were then being dosed either as frequently as once a week, and then able to extend out to a period of a minimum period of once monthly. So on the left, you can see that most of the patients that enrolled in the induction phase continued on to the optimization phase, with less than 10% of those patients discontinuing. And you can see the reasons for discontinuation listed here. And then of the ongoing, and newly enrolled patients in the optimization phase, you can see that we've had more discontinuations, but you have to bear in mind that, for some of these patients, the study has been going on for, up to 4 years. And the largest cause of discontinuation is the so-called other reasons. And many of those reasons are that, simply that, patients' lifestyle or, got in the way of them continuing to participate in research, or continuing to be able to follow up with the treatment as required. So some of these patients were discontinuing because they moved to new areas, or that they were not able to manage the logistical conflicts of the dosing. But then you also see the other reasons for discontinuation listed, including some patients who didn't respond, and some patients, who just did not want to continue. But at the time of this data cut, we had over 800 patients continuing. So, and let me actually just say, before I take a look at the data, because I realized that I don't have a slide on it, and it's likely to be a question. So the dosing is flexible. So patients could be on 56, 84, or for the elderly patients, the 28 milligram. So I know a question that's going to come up is, what dose were people generally on, and what dose frequency were people generally on? And I can say for that, during this optimization and maintenance phase, it was about 45 of patients receiving the 56 and 84 milligrams, and then a smaller number with patients receiving the 28 milligrams, and the same for the patients receiving the medication frequency of weekly or every other week, and then less than 15% of patients receive dosing for at a monthly schedule. So who were the patients, or who are the patients? They're still ongoing. So these, were mean age of about 50 years old, including, the patients range from in age from, 18 to 75. Patients were predominantly female, at 2/3 of patients were female. Patients were predominantly white. And this really reflects the regions of the world in which the study is conducted. And you can see that below that the majority of patients are coming from European countries, both East and West Europe, and about 30% from the United States. About 60% of patients had some form of employment. And then we list here that about a quarter of patients had a pre-existing diagnosis of hypertension and were being treated or are being treated with an antihypertensive medication. And we list this here because elevation of blood pressure is a well-known side effect, a transient side effect of ketamine and esketamine. So in terms of exposure, you can see that the median month of exposure during this trial so far has been about 2.5 years. That's the median. But you can see that there are about 15% of the patients that are ongoing that have been exposed for 3.5 years or more. So, like I said, it is a large and a long data set from which we can, evaluate long-term safety, I think, pretty well. So, in terms of the most frequent treatment emergent adverse events, both over the induction phase and over the long-term optimization and maintenance phase, the types and frequencies of the events are really similar. So we see dissociation, dizziness, nausea, vertigo, dysgeusia, or the bitter metallic taste that's associated with esketamine and ketamine, and headache are the most common in the induction phase, and those same events present as greater than 10% in the optimization phase as well. But you have to appreciate that the duration of the optimization phase is far longer than the induction phase. But essentially, we did not see any new findings during this during the optimization phase in terms of adverse event frequency. Now, we know that dissociation is a well-characterized side effect of ketamine and esketamine. I don't need to describe to this audience what that is. We saw pretty much equal proportion of patients experiencing this event to some degree that rose to the level of being considered an adverse event in both the induction and the optimization phase. Very few patients required treatment with concomitant medication for dissociation. And you can see there, the 0.6. And Jerry, you had mentioned in your talk about, what drug interactions you see with benzodiazepines, and that is the treatment that is typically recommended for severe dissociative reactions. And we did not need to utilize benzos frequently at all. The one thing we have learned in some of our other data sets is that what we do see when benzos are used concomitantly is that we do see higher sedation rates without much attenuation of the efficacy. But it does seem to result in greater sedation. None of the events of dissociation resulted in a serious adverse event requiring, any sort of hospitalization or what was be considered medically important. And the vast majority of essentially all of these events, are transient, time limited, and resolved on the day of dosing. And very few led to discontinuation. So in terms of sedation, we saw pretty consistent rates of sedation at 5.5 and 7% in the induction and optimization phase respectively. Again, these are limited to the day of dosing. There's not been any need for any sort of resuscitation or medical intervention or desaturation of oxygenation that has been associated with sedation in these patients, and none of these events led to withdrawal from study. We've also carefully monitored events related to suicidality, and there's a number of terms that are included in this list. Most specifically, suicidal ideation, attempt, completed suicide, but then there are other terms like self-injurious behavior or intentional overdose that are also included. And what we've seen overall is that 1.5% of patients reported some degree of suicidality in the induction phase, and 4.7% of patients had events in the optimization or maintenance phase. Only one patient has died by suicide in this program, and any suicide event is tragic. This is an event that occurred during the optimization phase in a 48-year-old male with a previous history of self-injurious behavior. And this was reported. This was reported at the time that the drug was registered in the United States. So there have not been any new events in the subsequent years during continuation of suicides. We have seen less than 1% of patients overall have events of suicidal ideation or suicide attempt that have resulted in hospitalization. And of course, we not only do we monitor these events in our clinical trials, but now that the drug is registered, we do monitor these events carefully through MedWatch and FAERS database, and evaluate the proportionality of these events compared to what the expected rate would be in this patient population. And to date, these rates are still falling below what we would expect to see in patients with both treatment-resistant depression and a history of active suicidal ideation and intent. But something to monitor very carefully. In the events in the trial, none of them were considered to be related to esketamine, or were doubtfully related to esketamine, based on the patient's history or the timing of the event relative to dosing. Now, I said that 25% of patients who enrolled in this long-term study have had a diagnosis of hypertension. Overall, we've seen about 16% of events related to increased blood pressure that were considered, treatment emergent adverse events. On the left, you see a slide or a picture looking at the rate of events per month over the course of the study, and then you can see the number of subjects that were actually treated or dosed. And basically, it looks like the rate of these events have remained pretty stable over time from induction to optimization. What I don't know, and because we only have sort of the preliminary analysis, to what extent these events were occurring in patients who had a history of hypertension. And but still the rates, are generally, about a 5% per month, and then the cumulative rate there. Most of these events have resolved on the day of dosing, and there was one event of hypertensive emergency, and that did occur in a patient who had a history of hypertension that was poorly controlled. But I should say that both in this study and in clinical practice, we do have parameters for blood pressure pre-dose that should be employed, prior to dosing. So patients should have stable blood pressure before receiving a dose, and with levels of below 140 over 90. So interstitial cystitis is a side effect that has been noted in street abusers of ketamine, and we've monitored for bladder symptoms over the course of the esketamine development program, initially using very specific measures of bladder symptoms in our early studies, and then in our follow-on studies using simple reports of adverse events related to urinary tract symptoms. And over the course of the SUSTAIN 3 study, we have not seen any cases of interstitial cystitis. Of course, we have had cases of urinary tract infections, which have generally been deemed to be of an infectious etiology based in urinalysis. Since we did see a rate of 12.1% of patients with UTIs, we went back to a claims database just to get some context to look at the rate of UTIs in patients with TRD, and found that those occurred in about 14% of patients. So we feel that the data in our patient population are really consistent with what you would expect to see in the TRD population. And so we have not seen, any interstitial cystitis or ulcerative cystitis thus far. Now, overall, we saw 13.1% of patients having serious adverse events. And just to remind people, serious adverse events are distinguished from treatment emergent adverse events in that they require hospitalization or are considered medically important or life-threatening or deemed to be that medically important by an investigator. But only 1% of the patients with SAEs of all the patients who had SAEs, the only event that occurred in greater than 1% was depression, leading to hospitalization. And this is, likely related to the underlying condition. And the rest of the events were various. The majority of the events were not considered to be related to treatment. We have had 4 deaths over the course of this SUSTAIN 3 study, and I did speak about the 48-year-old male who did die by suicide during the induction phase, and that occurred early in the course of this study, as did the next 2 events of a male who died in a bicycle accident. He was struck by an automobile during the optimization and maintenance phase, and a 73-year-old female who died by myocardial infarction during the optimization and maintenance phase. And both of those events were, I think, 6 days after the last dose. And at her last dose, her blood pressure was normal. So those events were considered unrelated to study medication. And then unfortunately, we've had a patient who died from COVID pneumonia during the optimization phase, and this was a 66-year-old male. So there were 4 deaths in this data cut that ended in May of 2020. Unfortunately, we have had another COVID death in the interim that will be included in the next analysis of the ongoing study. So one important question is, what are the long-term effects of esketamine on cognition? And we do know that the short-term effects, there is altered cognition, but what are the long-term effects? And so in this extension study, we have assessed patients with a Cogstate battery, as well as the Hopkins verbal learning test, the revised version. And so we have data on 130 patients out to 148 weeks. But beyond that, we have we have very small data sets. But if you look at the overall group mean performance on cognitive tests from baseline to 148 weeks, we do not see any change in baseline or slight improvement in cognitive performance. And this was observed both in the induction and optimization phase. Now, we have seen an interesting finding in patients greater than 65 in both this study and in our previous SUSTAIN 2 study. And I'll show you some data in a moment because it's actually been plotted for the earlier study. And on the overall cognition, including higher cognitive functions, we do not see any change from baseline to endpoint. But we have seen some slowing of reaction time in patients greater than 65 on simple and choice reaction time. And this, simple and choice reaction measure elements of attention and concentration. But the clinical meaningfulness of this slowing is difficult to ascertain because we don't see any changes or worsening on the higher cognitive functioning of working memory and visual learning, executive function, verbal learning. So it's really not clear what that slowing of reaction time is related to, although some who study normal cognitive aging have suggested that there is intrasubject variability as a part of normal aging, which may be what is leading to this slight slowing of reaction time in elderly. And you can also see that, by week 148, we also have very few patients from the elderly data set. So it was an N of 16 here. But here's the plot of the verbal learning from our double-blind maintenance phase. That's sustain 1, where you see that the patients who continue on esketamine actually have an improvement in verbal learning, and on the top of the slide, and that in an open label safety study, sustain 2, that also improved. And then here you can see that slight slowing of the reaction time in the elderly patients that was reported in sustain 2, and a similar effect that I just noted in sustain 3. So I just want to note quickly, as I see I'm over time here, we also have evaluated withdrawal symptoms, another important area of study for assessing long-term effects of intermittent dosing of ketamine and esketamine. And thus far, we have not had any reports of any sort of withdrawal symptoms across our long-term safety studies. We did not specifically assess withdrawal in sustain 3 with a formal measure, but we did use the physician's withdrawal checklist in sustain 2. And what you're looking at here is a graph that looks at the individual symptoms of the scale at the end of the study, and then weeks 1, 2, 3, 4 following exit from the study. And you really don't see any difference over that 4 weeks of follow-up on any of the symptoms that are related to withdrawal. And of course, many of these symptoms are similar to symptoms of depression, but are not unique to withdrawal, but we just did not see a signal there. So to summarize and wrap up, we really have no new safety signals that have come out of our long-term safety data now with intermittent dosing of up to 48 months, and everything has been consistent with what we saw both in our short and longer term studies. And that the findings that we know to be directly related to esketamine, such as dissociation and sedation, are transient and of mild and moderate intensity, and that essentially we did not see any new signals on the effect on cognition or withdrawal symptoms. So I will stop there. And I understand that we may be having some issues with the chat, but maybe they'll be fixed by the time we go to our discussion. So thanks.